Welcome back. Let's dive in. Physical restraint, if done incorrectly, can actually harm or even kill a patient. I want to highlight a few major risks and how to mitigate them. The biggest one we've mentioned is positional asphyxia. This is when a person's position, especially if prone or hogtied, prevents them from breathing effectively. There's documented evidence and studies showing how prone restraint can significantly reduce someone's ability to breathe and their cardiac output. People have died this way in law enforcement custody and in EMS when improperly restrained. So, to restate, never ever restrain someone face down or tie them in a way that chest expansion is limited. That includes those so called hobble restraints where hands and feet are tied together behind the back, absolutely forbidden in EMS. We keep them supine or semi Fowlers with airway monitored. If you ever did find a patient somehow ended up prone, like in a chaotic struggle, flip them face up immediately once you have control. Aspiration, we talked about. If they vomit on their back and you miss it, they could inhale that and choke. That's why we're always ready to turn them and suction. One precaution is to not overfeed an agitated patient water or anything by mouth. Sometimes bystanders try to give a combative person water thinking it'll help. It usually doesn't, and just increases aspiration risk. So, nothing by mouth for these patients, obviously, except meds if we get to that, like oral glucose in a hypoglycemic, and even then, that'd be tricky if they're combative. Circulation impairment is another risk. We bind someone too tight, especially with ropes or cuffs, and they could lose circulation to a limb or get nerve damage, like foot drop from perineal nerve compression or hand numbness from wrist restraint. Always pad the restraints if possible. Most commercial ones have padding built in. That two-finger check I mentioned is important. Also, a struggling patient can inadvertently tighten knots. We had a case where we used triangular bandages as wrist ties. The patient kept twisting and the cloth bunched into a rope and really constricted one wrist, causing swelling. We had to stop and loosen it, so keep checking and be ready to adjust. There's also the risk of the patient's physiological condition deteriorating due to the struggle. Excited delirium syndrome, although controversial as a term, basically describes when someone is in such an agitated state, often from stimulants or psychiatric issues, that their body is flooded with stress hormones, their temperature is high, they're acidotic, and they can suddenly collapse. Restraining these patients, while necessary, can sometimes precipitate that collapse. One precaution is to cool them if they're hyperthermic. Strip off excess clothing, use AC in the ambulance. Another is for ALS to sedate them to stop the struggle chemically. But as we said, chemical restraint is another topic, though it's good to remember that in a real case and need ALS backup. For head injured patients specifically, fighting against restraints can increase intracranial pressure, which is bad for brain injuries. So, again, if someone has a suspected head injury causing combativeness, we want to be extra gentle, quickly restrain to avoid prolonged fighting, and then treat the head injury, oxygen, perhaps elevate head a bit, transport to trauma center. Provider injuries. In all this, we can't forget our own safety. Many EMTs and medics get injured while trying to restrain patients. Back strain, fingers bitten, etc. Proper technique and adequate manpower help prevent that. Also consider defensive equipment. For example, heavy leather gloves can prevent bite injuries. Some providers will carry bite-resistant gloves. If the patient is known to have a communicable disease and is biting, that's a huge exposure risk. Use something as a bite blocker if needed while ensuring the airway is not compromised. And never put your face near the patient's face. A headbutt can break your nose. We also avoid things like using our knee or body weight in a way that could injure the patient, like kneeling on their neck or abdomen that could suffocate them or cause internal injuries. And obviously, do not strike the patient unless it's truly self-defense in a life-threatening scenario. We're healthcare providers, not police officers. We don't have the same allowances for using force beyond what's needed for medical restraint. Legally, any perceived excessive force can land us in trouble. We have to be able to say, I did only what was necessary to keep everyone safe. So avoid any maneuvers that look like cruelty or punishment. For instance, don't twist their arm until they scream just to teach them a lesson. Not only is that unethical, it's going to look awful if a witness videos it and in court. All right, next, let's touch a bit more on legal and ethical aspects, some of which we've woven in, but we'll focus on it now. Using physical restraint has legal implications, so we need to understand the boundaries. Firstly, always know your local protocols and laws. Most EMS agencies have specific guidelines for restraint. For example, some require online medical direction permission unless it's a dire emergency. Others might have banned certain methods altogether, like hog tying, which is widely banned, rightfully so. If your agency has a restraint protocol, follow it to the letter. It not only provides a standard of care, but also legally protects you if you act within it. There are several legal concepts to be aware of. If you restrain someone improperly or without justification, you could face allegations of assault, battery, or false imprisonment. Assault is basically making someone fear you will harm them, battery is the unlawful physical contact, and false imprisonment is restraining someone without legal cause. However, the law and society recognizes that EMS sometimes must restrain someone to save their life or others' lives. This falls under a doctrine of necessity or implied consent in emergencies. The key is that your actions must be reasonable. If a reasonable EMS provider in the same situation would also think restraint was necessary, you're on solid ground. If you went overboard, like tying down a mildly upset patient who wasn't truly dangerous, that's not justifiable. For example, say a patient was just verbally annoying but not physically threatening, and you tied them up because you got impatient. You could absolutely face a lawsuit or disciplinary action for that. Versus a patient actively punching, any jury or supervisor will understand you had to restrain them. Consent. Normally, we need consent to treat. When a patient is mentally incapacitated due to drugs, alcohol, hypoxia, psychiatric break, etc., the law generally gives us leeway to treat under implied consent, assuming they'd want us to if they were rational. Using restraints can be viewed as part of that necessary treatment if they truly need it for their own good. This aligns with the idea of preventing them from self harm. If a patient is competent and says, "Don't touch me, I'm refusing treatment," and they are not endangering anyone, we cannot restrain them just to treat them. That would violate their rights. We'd have to back off in that case, though we might involve law enforcement if we suspect there's more to it or if they're likely to become a danger. Now, often these situations blur lines of medical and law enforcement realms. If someone is truly a danger and a crime may have been committed, like assaulting responders, police will likely place them in custody. If a patient is placed on a psychiatric hold, that gives a legal framework that they are being held for evaluation and you are transporting under that authority. It's good to know what the process is locally, but regardless, EMS doesn't arrest people. We restrain for safety and medical reasons, not criminal. Even if they were committing a crime, our role is healthcare. Always keep that mindset. Involving law enforcement, if at all possible with a violent patient, get police on scene. Aside from the safety aspect, there's a legal protection aspect. If an officer orders or helps with the restraint, it carries legal weight. However, be mindful. If an officer's method, like handcuffs behind the back, is unsafe for medical reasons, you need to advocate for the patient's safety. You can say, "We need him on the stretcher, cuffs in front, or switch to our restraints, and you'll ride with us." Most cops understand the positional asphyxia issue nowadays. Work together, maintaining dignity and ethics. No matter how obnoxious or belligerent the patient is, we have to treat them as a human being in distress. Sometimes combative patients will hurl personal insults, maybe racial slurs, threats to sue you, etc. Do not respond in kind. Keep your cool. Remember that tip. Above all, keep cool. If you get angry and say, slam the patient or start insulting them back, you've crossed a professional line and it will not go well for you later. Not to mention, it's not providing care. So stay professional. If you feel yourself getting really frustrated, we're all human, it happens. Maybe swap out with a partner if possible for a breather. One trick ethically is to imagine everything you do is being recorded, which in this day and age, it probably is, either by bystanders' phones or the ambulance camera if you have one. If you're always aware of that, you tend to self correct to the proper behavior. You want any video to show you calmly trying to help and doing only what's necessary. Finally, after the call, there's often paperwork beyond just your PCR. Sometimes you need to notify a supervisor or fill out a special restraint form. Also, be prepared that you might have to justify your actions to hospital staff, your medical director, or even in court. As long as you followed protocol and documented well, you should be fine, which is a perfect segue into our next topic, documentation. Documentation for restraint incidents is absolutely crucial. These calls are high liability, meaning if something goes wrong, they'll be scrutinized. A well written report can be your best defense and also ensures continuity of care. When writing your PCR, start by describing the behavior of the patient in detail that led you to restrain them. Paint a word picture. Patient was screaming obscenities, pacing, then picked up a chair and attempted to throw it at crew. Those objective details show anyone reading exactly why you felt in danger. Avoid vague terms like patient was aggressive without examples. Instead, list specific actions or quotes if relevant. Patient yelled, "I'm going to kill you," and then swung fists at me. That is much more clear than just saying patient combative. It answers the all important question of why restraint was needed. Next, document what you did to try to avoid restraint, if time and situation allowed. For example, attempted to calm patient verbally for 5 minutes without success. Patient continued to escalate. Or, due to immediate risk of harm, no de escalation possible prior to restraint. This shows you didn't just jump in, you considered alternatives or tried them. Then describe the restraint process and methods. How many people were involved? Patient was restrained by 4 EMS providers and 2 police officers. Name or ID them if you can. Officer Smith from PD. Note position. Patient placed supine on stretcher. Note devices. Soft padded restraints applied to wrists and ankles, secured to stretcher frame. Additional stretcher straps applied across chest and thighs. If any improvisation was used, mention it. Use 2 cravats to secure legs due to patient size or such. Also note timing. Restraints applied at approximately 14:35. If law enforcement was involved, clarify that. Patient handcuffed by PD prior to EMS restraint, cuffs removed and replaced with EMS restraints with officer present. Or if cuffs stayed on, patient handcuffed, hands front, Officer Doe rode an ambulance to ED. That documentation can protect you, like if the patient later says the EMTs handcuffed me and hurt me, you can show it was actually police cuffs and the officer was present. Now, monitoring documentation, you need to show you did your due diligence after restraint. Document vital signs at intervals: 1440 heart rate 120, BP 150/90, respiration rate 24, SPO 2,9% on O2. Then 1445, patient still struggling, distal pulses present in all extremities, skin warm. If the patient calmed. 1450, patient less agitated, speaking incoherently, but no longer pulling at restraints. Note any interventions. Oxygen 15 liters via NRB applied, or IV established in right AC after restraint, 1000 milliliters normal saline running. Also note any injuries. Small laceration noted on patient's forehead post-restraint, approximately 1 inch, bleeding controlled with bandage. Or, no injuries noted on exam aside from old bruises. If the patient says you injured them, definitely record what they claim and what you observe. Similarly, if any crew member got hurt, that wouldn't necessarily go in PCR. That might be separate internal incident report, but could be mentioned if relevant. During restraint, patient kicked EMT Jones in the thigh. EMT Jones with minor pain, continued care. Importantly, answer the question: why was this necessary and what would likely have happened if we didn't restrain? Your narrative might include a line like, given the patient's continued attempts to strike crew and run into the street, physical restraint was necessary to prevent immediate harm to patient and providers. That kind of summary helps reviewers or legal folks see your rationale clearly. Keep your tone professional and factual. Even if the patient was the worst you've ever seen, don't use judgmental language like patient was a raging maniac. That has no place in a legal document. Instead, patient exhibited extreme agitation, shouting incoherently, and was physically combative. Stick to describing, not judging. At the hospital, mention how you transferred care. Patient turned over to ER staff in 4-point restraints. Report given to RN Smith. ED security and staff informed of restraint and assisted with transfer to hospital bed. If you remove restraints at the hospital, note EMS restraints removed at 14:55 upon arrival after hospital staff applied their restraints. Lastly, if medical control was contacted, write medical control doctor. Green consulted at 14:30, orders received to restrain patient, or whoever authorized if needed. Thorough documentation cannot be overstated. Assume whatever you write will be scrutinized. A good way to check yourself: reread your narrative and ask, does this fully justify why we restrained and demonstrate that we cared for the patient appropriately after? If yes, you're probably in good shape. It might feel like writing a mini novel, but it's worth it. In closing, restraining a patient is something we never want to have to do. It's risky and it's challenging, but sometimes it's absolutely necessary and it saves lives. When done properly, it protects the patient from themselves and protects us from injury so we can continue to help others. As EMS providers, our priority is to do no harm, and that includes not harming the patient while restraining. So use these best practices. De-escalate when you can, restrain when you must, and always do it safely and professionally. Thank you for joining me. Stay safe out there.